Hi, it's Erin. I'm your regular co-host of First Bite. First of all, I want to thank y'all so much for tuning and listening to First Bite. We've been incredibly encouraged and excited by the feedback we've received and are looking forward to the future. In the meantime, if you've been enjoying First Bite, please take a moment, maybe pause your device to subscribe, leave a review on iTunes, Stitcher, or wherever you're listening. This podcast started out as a small idea to bring convenient, tangible resources to SLPs and other professionals, and we value your feedback more than anything. Leaving those reviews truly helps us out. Enjoy the episode, and thanks for listening.
Hey, Erin, have you heard that we have a promotional code for speechtherapypd.com?
I think I heard the same thing.
Yes. So as if we both hadn't heard that, but it's First Bite. So if you log on to speechtherapypd.com and enter the promotional code First Bite, it takes $10 off an annual subscription. And Erin, do you want to?
That includes all the pod courses.
Yes. And we have 4 now. I'm not sure if y'all knew that. We have 4. We have First Bite. Yeah, we do. It's Speech Uncensored. And in case y'all haven't heard of this lovely lady, she focuses on adults. And I know that there's a fair few of you out there that PRN in peds and or PRN in adults. So be sure to check out Speech Uncensored. And it also includes the Speech Link and the SLP Now podcast with Miss Marisha, who I like fangirl crush. She's awesome. Okay. All right. So promo code is
First Bite.
Whoop, whoop. And don't let it autocorrect you to BYTE because it did that to me a couple times. So there it is. Woohoo! Hi, folks, and welcome to First Bite. Fed, fun, functional resources for the pediatric clinician. I am your host on this nerd venture, Michelle Dawson, MS, CCC, SLP, the All Things Peds SLP. I am a colleague in the trenches of home health early intervention, right there with you. I run my own private practice, Heartwood Speech Therapy, in Coletown, South Carolina, and guest lecture nationwide on best practices for early intervention for the medically fragile child. First Bite's mission is short and sweet, to bring light and hope to the world for the pediatric clinician, parent, or advocate. In this podcast, we cover everything from AAC to breastfeeding, best practice for running a private practice, and all the nitty-gritty details involving feeding and swallowing by interviewing the subject matter experts themselves. We bring the data to you. Every 4th episode, I am joined by the lovely Erin Forward, MSP, CF, SLP, a Yankee transplant who actually inspired this journey and who also walks the wild, woolly, and sometimes sticky walk of early intervention with us. Sit back, relax, and watch out for all the squirrels and enjoy this geeky gig brought to you by SpeechTherapyPD.com. So today's topic falls in the fed and fun categories, and I am super geeking out because this is a topic that is way past due in my humble opinion. Today, we are talking all things medications. Okay, so here's the backstory. Once upon a lifetime ago, I was a clinical fellow back in Newport News, Virginia, and if you're from that neck of the woods, then you may have heard it called bad news. Ha ha ha, bad news VA. Hoy, that takes a girl back. All right. So anyway, there was a dynamite lecture series that came into town by Tom Francesni. And I hope I'm saying that right. There's a lot of consonant vowel combos there. Tom Francesni, MS, CCC, SLP. And it was all about the Fraser-free water protocol and the impact of GERD on dysphagia. Y'all, it was amazing. To this day, that sweet man in his stylish purple velour 3-piece suit with a silk cravat had like a little pearl button pin right in the middle. That will always be my favorite live lecture that I have ever seen. He was brilliant as he was kind. So do yourself a solid and go check out one of his lectures. Now, outside of his classroom, there was a lovely little table with all these little books for sale. And one of them was a little red book that I have since dubbed as the Drugs and Dysphagia Bible. Pardon the blasphemy, it is called Drugs and Dysphagia. So I picked it up. Y'all, that one little red book changed my stars and opened my mind to an entirely new world of how medications can actually induce a dysphagia or cause errors downstream that can result in diminished PO intake. Now, if y'all haven't heard of that book or the new one, then do yourself and your evidence-based practice a solid and go pick it up. So fast forward a few years, and I came across the amazing Lisa Young Milliken, MACCC, SLP, FNAP, and CDP. And oh my heavens, what a fine she is. This Lone Star lady has dedicated her life to pursuing best practice for medically complex patients. And in her pursuit, she's become a passionate advocate about the impact that medications can have on a person and their ability for PO. Now, I'm not quite sure how I did it, but I managed to sweet talk her and convince her into bringing her knowledge and her amazing spark to First Bite. And y'all, here she is. So Lisa, thank you so much. Like, I have so many questions. I feel like that girl with the brain on fire movie because like that's kind of the pace that I'm keeping internally right now. But like my first one is, what in the world does all that alphabet soup mean after your name?
You're so funny. Well, of course, the first is just the master's in speech pathology, and I'm kind of old, so in the 80s when I got my master's, we only had Master of Arts back then. Anyway, the other letters is I'm a fellow of the National Academy of Practice, which is an amazing organization that focuses on interprofessional practice and working with professionals just across the continuum to maximize the abilities of a client by looking at how we can all help rather than looking through a single set of eyes of our own profession alone. So it takes a team. That's what I call that.
Yes.
And then the CDP is I'm a certified dementia practitioner. Traditionally, I have mostly worked with adults and geriatrics. And then a few years ago, I really started teaching quite a bit on the effect of medications on their condition, on their function. I've worked with CFs for 30 years, and I now teach them to go first look at their meds, and you'll learn a lot more about them because that's just as important as the conditions that you've seen, the diagnoses and conditions that you've seen on their chart. And then just recently, I've realized that the medications for infants, especially those before, even before they're 4 or 5, is very similar to the medications that I've studied for so many years in the older people because of their completely different kidney and liver function. Their blood plasma is different. Their body is just different from the older child and adult. So the younger child has become fascinating to see how these different medications affect them too. So it's kind of full circle what we do and how we can help each other and how we can consider medications as a big part of practice. And I just wish I knew when I first was in grad school or first got out of grad school about medications as much as I now do, and yet I'm still learning so much about medications, but it's really important. Anyway, that's what my letters are.
Oh, well, one, I've never heard of the National Academy of Practitioners. So I just did a Google search and now I will have to spend at least an evening looking into all of that. That's amazing. But you absolutely summed it up. When I first started, nobody in graduate school or undergraduate had even brought to my attention that medications could impact a body and actually have a negative effect on their PO intake. And it wasn't until that lecture, I mean, I was a CF, but when you're a CF, I mean, heavens to Betsy's, you're just trying to figure out like the computer system or like navigate personalities or like, God forbid you work in a heavy female dominated department and then everybody starts cycling together, because I have been there and done that and remember that like just that parameter in and of itself. But somebody out there listening is like, oh yeah, I get that. But then there's medications and how And the problem that I faced was I thought I knew medications, which is hysterical because I don't have a freaking clue. I'm barely scratching the surface. But, I mean, I would see a lot of like GERD medicines when I first started working with pediatrics. And I'm like, oh, great, they have GERD. But then I would get more and more complex patients. And then I started getting cardiac patients. And I'm like, I have no idea. And then one mother, I distinctly remember her saying, yeah, we started some new medications and I don't really remember what it's supposed to do, but it's called Lasix. And, you know, the baby had Down syndrome and had at least one hole in the heart. And I was like, you have a 4-month-old on Lasix. That's pretty profound. like, but had I not had at least a scratching of the surface, I would be afraid of what my recommendations would have been had I not had that, at least that limited knowledge. So, yes. So thank you for coming aboard today and doing all these things. I am grateful for you. Okay, so let's go into it. What are some of the most typical drug classes that may result in adverse effects in children, especially those which may affect a child's swallowing or cognitive skills as we work with them in like a therapy setting, either home health or outpatient clinic or like, a little clinic setting?
Sure. Well, I've learned it's really helpful to understand which medicines have something called an anticholinergic property. So, if I'm teaching this in a live class, I'll have everybody repeat after me. Anticholinergic. Yep, anticholinergic. There's a lot of drug classes which have this property. So, it's not a drug class in itself, it's a characteristic of a medication. And I'll just describe in a minute what it's doing to the body. But it's so important because of the side effects a medication may have once it has this anticholinergic property. So the first thing that comes to our mind as speech pathologists working with swallowing is that they have decreased saliva production. So they'll have dry mouth or xerostomia. They could also have blurred vision, dry eyes, constipation, dizziness, cognitive problems, drowsiness, memory problems, decreased sweating, decreased ability to go to the bathroom to urinate. And so because there's so many classes, there's like 400 different drugs with anticholinergic properties, and you could look it up. Is this an anticholinergic? Then it tells you immediately, I'm dealing with decreased saliva, I'm dealing with drowsiness, I'm dealing with, those things that I mentioned. So it's important to know that, what falls under this property, which drug classes fall under that. And it's things like antidepressants, which we may see children on, antihistamines if they have allergies, muscle relaxants, antivertigos, which may not be as predominant in young children, antipsychotics, antiemetics if there's if they have nausea, which we see as a side effect of another med, antispasmodics, which we see with the GI tract, antidiarrheal meds, all of those, a lot of meds that have anti in front of them may have anticholinergic properties. So if you only learn one thing today, learn how to go look up, does it have an anticholinergic property? And you would think, okay, we've got decreased saliva, we've got, all those other things we're going to have to deal with. So if they have that property, they block the neurotransmitter acetylcholine at the synapse level in the central nervous system, as well as in the peripheral nervous system. And then they inhibit the parasympathetic nerve impulses. So in addition to those things we just talked about, the dry eyes, blurred vision, dry mouth, constipation, maybe even some gastrointestinal problems, they could also, because of blocking this neurotransmitter acetylcholine, they could have impaired verbal learning of new material and declarative memory. So even though we're talking more about swallowing and eating and feeding patterns and how they're affected, we always have to take into account the cognitive abilities as well, especially if they're a young child. We're trying to teach them new strategies that they may not be able to learn yet because of this cognitive effort. So just keeping all of that in mind, it's also important to know that sometimes, and really many times from a research standpoint, it's not reported um, to be to be if it's not reported to be tracked in the clinical setting that, oh, this, they could have a memory impairment or not be learning the strategies we're teaching them because of the anticholinergic property. So the research says that in the clinical setting, the adverse consequences of anticholinergic treatments often go unchecked. And if they're taking more than one of these, like if, let's say they're taking two, maybe one to stop the diarrhea, one to stop the nausea, maybe one that's antihistamine, then have a profound effect. You have this much greater, even more toxic level of these anticholinergic properties, and they could become a really negative complication. So that's the
Good
first thing.
God.
Mhm.
Good God. I'm just thinking that sums up like every kid on my caseload. Okay,
I
wait.
know.
All right, hold on. Folks, I have to spell this for you because just so you know, ANTI, and then
Hmm.
say this again because I have a hard time with multisyllabic words.
Sure.
Colin
So cholinergic. So that's it. CHOLINERGIC.
O-L-I-N. Okay. All
So
right.
anticholinergic.
Oh my stars. Okay, there it is. Thank you for spelling that because I know somebody else out there does a really good job with feeding and swallowing and also struggles with phonemic spelling like me. So thank you. Okay, so that's the first factor that we need to look for.
Another thing about anticholinergics is when I first studied the negative effects, I thought, well, then why would anyone take these? But they're really important. For instance, if you need a bronchodilator, if your passages in the lungs, the bronchi, if they have swelling and tissues going together, you can't get the airway. These bronchodilators are needed to open up those airways. But the same thing that blocks the swelling and the inflammation also dries the mouth and dries the secretions and does other things. So they are needed, and I'll talk about that a lot through the rest of this talk of why every medication that has a good side also has a bad side, and physicians and the interprofessional team has to weigh, is the good outweighing the bad? And so we kind of just have to keep it all into perspective.
Okay. I can keep it into perspective. I'm really doing a hard job of keeping anxiety at bay over this topic. But like, all right, perspective. I like that. Okay. So very many of our complex pediatric patients have GERD.
Yep.
Can we go into the GERD? Are you ready to switch into the GERD?
Sure.
Okay, because
Yes.
there's I'm part of a listserv that's actually going into it's the international, it's a new board that's getting formed, but right now they have a Google group and they've been sharing all of the esophagan and the national esophagan position statements on the GERD medicines. But enlighten us about those PPIs and those H2RAs.
Okay. So this could be like a 3-hour talk all by itself. And I'm going to try to hit the highlights, that what we can cover in a little bit of time and still get to a few other meds as well.
Okay.
So PPIs, proton pump inhibitors, they do exactly what the name says. These meds will bind to and block the acid producing pumps in the stomach. And so the short term effects, just to hit that first, and then I'll talk some more about the individual meds. The short term effects of most of the PPIs in children are headaches, diarrhea, constipation, and nausea. So that is helping them to be able to digest their food, but it's also giving some negative consequences of the nausea that makes them not want to eat. Of course, who wants to eat when they're nauseous? The
Nobody.
diarrhea, right? The
Yeah.
constipation. So the whole GI tract has negative effects as well as, being able to benefit from these PPIs. And then more serious, that's just the normal side effects. Then there's more serious side effects. In some infants include respiratory tract infections that are common, especially lower respiratory tract infections, in those children aged around 1 to 11. And then the side effects can be more significant to include more vomiting, more diarrhea, more abdominal pain, etc. So some of the examples of PPIs for treating GERD is the oroprharyngeal, which is the acid hex for children as young as age 1. And then there's also the omeprazole or Prilosec. And that can be age 1 or older, but there's also the physician has to take into account, they have to be a certain body weight and all that kind of thing. Some studies have shown that the Prilosec or the omeprazole has been found to lead to food aversion and gag reflex in the oral stage. But then when they studied those effects more specifically, they thought, well, that could have also been secondary to the reflex that they were treating. So they're not saying it caused the gag reflex. They just saw it frequently, and maybe if the medication wasn't completely taking care of that, so they were still seeing food aversion and gag reflex.
Okay.
And then some PPIs for treating the esophageal erosion or erosive esophagitis is more of the Nexium, the esomeprazole, same thing, or Protonix, the pantoprazole. The same kind of side effects, but with Nexium, omeprazole, we also see constipation, dry mouth, and drowsiness. And then with the Protonix, it's about the same as the others, but it cannot be used according to the regulations until a child is 5 or older. So I'm going to talk about some other short and long-term effects of those in a bit. But let's next go to the H2RA. So these, of course, are the histamine 2 receptor antagonists. So H2RAs, they're also referred to as H2 blockers. These act by reducing the histamine-induced gastric acid secretion and the pepsin output.
Okay.
The good news is there. Oh, go ahead.
Okay, so the way I made it work in my head is that the PPIs tell the pumps to shush and turn off, and the H2RAs neutralize what's already out there.
Pretty much. And the H2RAs are also helpful more in the evening before the child goes to sleep, and it's more effective in the evening. But the H2RAs are not as effective. And so we usually see no long-term effects of H2RAs because they're not given long-term, because they have something called tachyphylaxis, and that just means they have a decrease in response to every dose. So you need to give a greater and greater dose for the person to get the same effect, and eventually they get no effect from it at all, according to the manufacturers.
So aren't I've seen a lot of really amazing GIs put a kid on for 30 days and then off for 30 days, on for 30 days and then off for 30 days for the H2RAs. That's
Right.
kind of like what I've seen.
That's why.
Yeah.
Because after 30 days, it may not affect them at all. It may, as well be a sugar pill or something, because it's not going to affect their system. And that's why they would take them off for a while. And when they put them back on, they see it start to work initially, and then it starts to lose more and more response with every dosage. So that
these are the deans, right? Like the ranitidine.
Exactly. So ranitidine is Zantac. The famotidine is the Pepcid, and the cimetidine is Tagamet.
And those are the ones that are like bad choice makers right now, apparently, and getting pulled off the market, correct? The Zantac.
There are some significant side effects, although, again, they're not given for very long since they stopped working. So they're not really being touted as bad because their effectiveness keeps decreasing. But the common side effects with the Zantac, for instance, are headache, pain, gastroenteritis, which really defeats the purpose, somnolence, sleepiness, right? And even pneumonia and more infections. So, there's a lot of side effects. It's kind of like when you see a commercial and it says, caution, this may cause death. Well, if that's, what are the advantages if the disadvantages are greater?
Oh my God, that's great. Like, this will make you feel amazing for 20 minutes and then you'll die.
Yes, we can't, or it may not work for you at all. It may work for others.
God.
Exactly.
Well,
Okay, so all of these meds, the PPIs and the H2RAs, are called the anti-secretory meds. It means it decreases the acid secretions, is kind of what that means. Um, Use of these meds, especially the PPIs, which we do see more long-term for acid suppression, like if we're stopping the production, or we're trying to heal the existing erosion, or we're trying to, whatever, at whatever level, we're trying to decrease those secretions. The problem is they interfere with the natural defenses against the gastric bacterial colonization. So the body has a lot of good bacteria that's fighting for you. And when you take these acid suppressants, which you may need because you're trying to stop the acid from, preventing you from eating at all, well, then you're also decreasing the good bacteria colonization. It also can decrease protein digestion. It can trigger allergic sensitization to dietary peptides. So, and I'll talk more about what happens in the normal digestive system in a little bit, but just know that when we're suppressing the acid production, because let's say their body's producing too much, or it's leaving the stomach, going back up into the esophagus and through the lower esophageal sphincter, it's causing lots of crazy havoc. If we suppress that too much, then it really messes up the entire GI tract. It could lead to elevated gastrins in the blood. It could lead to carcinoid formations or cancers. It could definitely lead to vitamin B12 deficiency, because those nutrients like B12 does not get absorbed into the bloodstream, into the system, because we need the acid, a small amount of acid, the right amount to help us absorb that. And it can lead to hypomagnesium, just too low of magnesium. It could lead to atrophic gastritis, which becomes very insidious and negative over time.
what is that? What is atrophic gastritis?
Um, that's kind of where, like, the stomach starts to erode itself because it's not functioning properly. The lining, the mucosal lining, um, just this chronic gastritis. And then it can also lead to lower respiratory infections, pneumonia, like acquired pneumonias. It can, of course, I think a lot of people recently read more, just because there's more recent studies on reduced bone mineralization that leads to fractures once they get older. Could even lead to C. difficile colitis. So there's a lot of negative effects, especially long term. So as a result of all that, physicians have to consider, what are the advantages of protecting from real tissue damage that could be life altering, or
Or
and as well as healing existing mucosal damage against all these risks of decreased, from decreased nutrient absorption to a just a full inefficient GI tract, all the way from the oral stage through the intestines. And then, as a result, the recommended solutions are to first, let's all try the non-pharmacological measures. And this is where I love, back to the interprofessional standpoint, where we work with our PT and OT colleagues, nurses, physicians, everybody. PT and OT colleagues teach us a lot about, as well as, we share with them. But if we work together, we learn a lot about positioning, like the role of what's going on with the spine and the ribs, and the whole posturing status, and how we could address a lot of things that way. And then when that doesn't help, because clearly that's not going to help all of our kids with, or even neonates and preterm babies, that's not going to fully solve the problem. When they do need to recommend the pharmacological measures, then all of the research says we have to use the minimum number of acid suppressant medicines at the lowest dose for the shortest period of time, to minimize both the rate and the severity of those adverse effects.
Mhm.
So it's kind of that big picture.
Two thoughts real quick, folks. When you see a child posturing, an infant posturing on the bottle, yes, most of us assume GERD first. However, we should also be building on that interprofessional practice, we should also be sending them to the allergist while we're sending them for a GI consult, because many of these infants actually have a dairy or soy allergy or intolerance. And
Yes.
sometimes the intolerance will present as posturing, emesis, vomit, the whole 9 yards. So while and that's one thing that's often stated, is that we are, as a society, quicker to put them on the lowest dose of the H2RAs or the PPIs, and then afterwards going, oh, but wait, it could be, when in fact, if we eliminated the allergen first, it will naturally help. So
And
yeah.
let me share some other things about GERD, because every time I talk about meds, because meds by themselves can sound so horrible, they can sound like the culprit, the bad thing. But I also always like to say, let's not blame everything on the meds, and
Mhm.
let's look at the holistic picture. In this case, it could be of the preterm baby or of the
Mhm.
infant or the young child, of everything else that's going on. So the med itself may not be what's stopping those hunger cues. So I wanted to talk a little bit more about that, to fully understand why that child may not want to eat and how they may not be getting hunger cues as children without GERD get. So even if they weren't on any meds, if they have GERD, they're not going to be getting hunger cues like they would if they did not have GERD. So picture this: a normal gastrointestinal system without GERD releases just the right amount and just the most perfect timing of enzymes and acids at all levels throughout the entire digestive tract, through the colon. And that's what normal digestion looks like. So if somebody has that, they have normal hunger cues. They cry when they're hungry, or if they're older, they ask to eat. They look forward to eating, and they, desire to eat. But if they have GERD, they could be experiencing reflux, nausea, vomiting, retching, their little body's retching as they're throwing up, or pain either during or after they eat. So that's what happened to you every time you ate. Would you want to eat? So when
No,
they're, yeah, so they're,
that's
and
like us getting food poisoning and not
yes,
wanting to go back to that restaurant.
yes. So their little body responds by developing this initial reaction to food, like that was bad. If I smell this, I don't want that. Or if somebody approaches me with a bottle or with something, I don't want that. So they have this negative association with food. And they also may interpret hunger signals as nausea or pain. It's kind of like that Pavlovian thing, Once every time they got hungry, that they were given food and they immediately felt pain or nausea. So now that they're getting hunger cues, they're perceiving those as pain or nausea. And then children with sensory integration difficulties or sensory defensiveness could experience the GI discomfort with even greater internal distress. So they could often appear to have this sensory memory of esophagitis or reflux or general discomfort, even after the problem has been resolved. So, like, you've treated it, you've addressed it, it's good, but they don't want to go there anymore because of this sensory memory. And because the memory associated with food and discomfort is so strong, then some children may continue to fear that taking anything by mouth could be painful or have bad results. But the adult, who may be the parent or the therapist or the nurse, may only see external signs of vomiting. That maybe be the only time that you know. You
Mhm.
don't know when they're feeling nauseous, or they can't tell you. You don't know when they're feeling this internal pain. Maybe you're not recognizing that, because lots of other things are going on. They may just have some reflex that they can sense and feel, but it's hard to interpret that until it's more severe. Also, they could have, the same child with GERD could have a delayed gastric emptying time where food stays in the stomach
Mhm.
for hours. It doesn't pass readily into the intestines. A typical meal should be of a child without significant GERD. And I also should say that every infant, or not every, but most, some studies even say 70% of all infants have some degree of GERD, although it may still be considered normal, like a happy spitter or something. And
We've actually covered that. Folks, a lot of times it's the underdevelopment or the innervation, it's the enteric nerve system of the GI tract.
yes,
So
yes.
And what happens is that the enteric nerve system, the nerve system of the GI tract, is not fully developed until a child is full term plus 3 to 4 months. So the reason why we see the most spit up around month 3 or 4 for a typically developing child that does not have GERD, they're the quote unquote happy spitters. It's the storm before the calm. It's the nerve system literally working out all the kinks in the esophagus and the stomach. And sometimes a byproduct of that is a spark, a misfire, a little bit of spit up, and then they move on, truck along, and then go on about their business. But that's just the nerve system finishing development. We get
Right.
under the misinformation and misguidance that when a baby is full term, they come out fully developed. They're not. It's just that if they were to actually cook the additional 3 months in utero, we as a species would have died off. They never would have made it through our pelvic floor. So they're more like full term around month 3 or 4 after being born full term. And let's be honest, most of us working in our worlds, we typically don't see full term, typically developing babies. So sorry,
So,
big squirrel, passionate
oh,
squirrel on
that
my
was
part.
good though. That was good though. And some of the studies even say that at age 1, we may still see like 20 to 40% with GERD just from the fact that they're still developing, especially if they were preterm, for instance. So, anyway, some children with GERD have a delayed gastric emptying time, and if they do, the last meal that they had could still be in their stomach 3 to 4 hours later, and we're expecting, with the if they didn't have it, they would be ready to eat after 2 hours. Uh, Another thing is constipation. So that happens, of course, when food residents are not propelled effectively through the intestines because of an ineffective, inefficient GI system. And it gives them a feeling of fullness and generalized discomfort for longer periods of time. And then that also contributes to mild nausea, feelings of malaise and fatigue, a general lack of interest in eating. So that's another thing we see. And then the last thing with GERD before we go to the next question is children with GERD could also be taking other meds. And we could see that similar effects from other medications, like that, for instance, may cause constipation, like those for muscle relaxation or seizures. And that could include baclofen, Depakote, Klonopin, Tegretol, Dilantin, and Valium. And if they are experiencing side effects from these meds, they may be even more disinterested in eating or really want to avoid food because it brings them even more discomfort. So that's the last thing on that question.
You just summed up a kid that I see. I've got this kiddo that has feeding tube dependency, trauma, a rare genetic condition, had to have the feeding tube placed not due to aspiration, but due to overall motor planning and just general discoordination and endurance. Like it was taking longer to take food in due to the motor planning. Like, you see what I'm saying?
Mm-hmm.
And I suspected delayed gastric emptying and was shot down, shot down, shot down. Finally, we got a second opinion from GI. And the reason we had so much emesis was delayed gastric emptying. And overall, when they actually went in and did the imaging, the size of the stomach was so small
Mm.
that the baby couldn't take in even the targeted volume. So they had to end up changing feeds around, going to overnight feeds, slowing the rate just to get calories met. And here we are so many months later,
Right.
and all these combinations, we have zero desire, total PO aversions with every trial. And I told the family, we just need time. And to segue to the next question, the baby started having febrile seizures.
Mm.
So they started on phenobarbital.
Oh.
I'm telling you, it was the highest dose of phenobarbital I have ever seen a kid on. And I questioned why and was shot down, shot down, shot down. I'm like, the kid's still having febrile seizures on the phenobarbital. Like, maybe we should look at a more holistic approach. Like, because there was some jerks, there were some things like, what about the ketogenic diet? What about CBD oil? This is like the big bad ugly drug,
Mm.
and they're now tapering. So I'm interested to see what the next few weeks and months bring with the eradication of phenobarbital, but we're still on, God help me, is it Ariped? Am I pronouncing that right for the GI motility? I
I think
think the medication was Ariped, but I
mhm.
could be mispronouncing that. Okay, but squirrel. Okay. So again, we could talk all day on GERD, and I kind of have a notion maybe to see if I could sweet talk you into coming back later this spring just to do one on GERD.
There's a lot.
But we do have to go into the uglier ones, the seizure medications,
Mhm.
because Capra, Onfi, Delanton. Talk to me about those, because I remember one neurologist explaining it to me. I can't just tell one cranial nerve to shush. If I tell one, I tell all of
Right.
them to shush. And then in walks the SLP or the OT, and we're like, hey, take a bite. It's cool. It's delicious. And the kid has zero desire. So
Mhm.
go team. Enlighten us, friend.
Well, so the anti-epileptics work by just decreasing the membrane excitability, and then that can increase the postsynaptic inhibition, or it could kind of just alter the synchronization of all the neural networks to help decrease the excessive neuronal excitability that we see with seizures. And so the common side effects in general of most of the anti-epileptics are the slowed motor and psychomotor speed. So we see that affecting the just any motor abilities to include eating and the voluntary and involuntary motor components of swallowing. And we also see more decreased attention and mild memory impairment, and those can affect just across the board different things that we're trying to teach. But unlike adults who have seizures and are on anti-epileptics, the cognitive side effects in children is happening at the time that they should be normally developing those cognitive and psychosocial skills. And the treatment decisions that are made in childhood usually have lifelong implications. They're not taken off of these meds. They need them to decrease the seizures. And then we see a lot of studies of the people who started these meds as children, what they become as adults, and their difficulty with jobs and with functioning, memory, attention, and all of that. Lower high school graduates, college graduates, all of that. Anyway, so the greatest concern of cognitive side effects that leads into being able to sequence steps and learn new strategies is a newer generation of the anti-epileptics called Topamax or the topiramate, and that's for children aged 6 to 15. The cognitive side effects of these kids are found to be called slightly worse overall than all the others. That is
Oh,
just in
that's
research. Yeah,
okay.
slightly worse overall than those taking the older and more known medications. Specifically, they had more verbal memory problems, including more word finding difficulties, more fluency issues, and to a
This
smaller
is
degree,
executive functioning.
exactly. And then the Zonegran is kind of like Topamax, only to a smaller degree. That's also being questioned. Zonisamide is the generic name, although there's less studies on that. But we are seeing somnolence, anorexia, dizziness, ataxia, agitation or irritability, difficulty with memory, and concentration with the Zonogram.
And
So next,
Topamax is also given for migraines, right?
yes, I believe so.
Because I have a dear friend whose son has seizures. He has a genetic condition and autism spectrum disorders, but he was starting with migraines, and they put him on Topamax, and he was, I didn't think, old enough to take Topamax, and they put him on it, and it's
What
this
was his age? About like
um
elementary
well,
school
now
or?
he's 15, and
Oh,
I
okay.
think he got put on when he was 13.
Okay.
But like, I in Michelle Land thought Topamax was like an adult thing, not for, wow. I wonder
Yes,
if,
it
oh,
was
I'm
approved for
so
children
calling her.
at much lower dosages, of course. But yep, and that's considered a newer anti-epileptic because it was not given. Maybe it was probably started in the last 5 to 10 years, maybe.
Yeah. Huh.
So The next one are the phenobarbital that you mentioned and the benzodiazepines. So we'll kind of class those together. These, before these newer antiepileptics like the Topamax, these were considered to be the greatest risk of cognitive side effects, and they still are high risk. They have displayed IQ declines, and while the IQs may improve a little bit after it's discontinued, there seems to be long-term achievement effects. Even when they were discontinued and tested 3 to 5 years later, they still had more long-term effects. And that suggested a complex interaction of the antiepileptics with developmental maturation, because they were supposed to be in the process of developing at the time that they were taking those, which that limited how they could develop. So concerns exist that using such antiepileptics with cognitive side effects could result in more significant impairment over extended periods of time. And then next are other common antiepileptics, the Tegretol, Dilantin, Depicon. I'll just go with their brand names. It's easier to say. But the side effects of those include modest psychomotor slowing. So all of the things you need motor skills for was seen at a modest effect, and decreased attention and memory. And then in the studies, they also cited quality of life and memory were affected as well. I think we're mostly concerned about the psychomotor slowing because we need that skill in so many things that we teach, including the swallowing function. And then kind of maybe a little bit better news is Keppra. It is associated with reports of some irritability and aggression, but it seemed to have, on the more recent studies, a favorable cognitive side effect profile. In a study they did with kids on the with autism on the spectrum, Keppra had beneficial effects on attention, hyperactivity, and mood instability. It helped to kind of bring that together. So unlike other antiepileptics, Keppra was not associated with a change in EEG test or visual evoked potential parameters. So that seemed to be a little more promising. And then Onvi was used in other countries, was not approved in the US until 2011. Children on this, called clobazam, that's how I pronounce it, or Onvi, had similar neuropsychological profiles as the Tegretol or the Dilantin after 1 year of treatment, with the exception of one test psychomotor processing speed of the WISC-R coding. The cognitive effects could not be determined because negative cognitive effects associated with the antiepileptic treatment could have been offset by performance improvement from giving the same test over and over. But the common side effects of Onfi included fever, lethargy or sleepiness, drooling, increased saliva, and constipation. So those affected the GI system as well.
Well,
and then
doesn't
on a
that make you
related
want
note,
to eat? I'm just
I
saying,
know.
if you're drooling and you have a
Exactly.
fever and lethargy, it's perfect time for a
Oh,
milkshake.
I'm so hungry. Right, exactly. And then on a related note about this drug class, there's a few other things to know about medications for hyperactivity or seizures, and some, may take both. Medications also seen to have a side effect of reduced appetite or anorexia included Ritalin, Prozac, Depakote, and Klonopin. And then other meds for muscle relaxation and seizures that had effects of nausea and vomiting were Valium, Baclofen, Dilantin, Depakote, Klonopin, and Tegretol. So that's it for the seizure discussion part of this brief talk.
Okay. All right. So 2 to add, Dilantin. I remember this one. It can cause mucositis. It can cause a breakdown of the mucosal lining of the oral tissues. And it also can cause, help me out here, gingival hyperplasia. Am I saying that right?
Yeah, so if you see somebody where their gums look like they may have false teeth or something, or they've had significant kind of gum work, or it just looks kind of different, a lot of times you can quickly say, yep, they're on Dilantin. You can just
Okay, so ladies and gents that are listening, if you're on these medications, not only are you going to have difficulties with the psychomotor properties or planning out PO intake, if you're on something like Dilantin, when these infants are teething, and remember, like a tooth erupts through the gum line, right? And that can cause inflammation, irritability. So then the gum line reacts by swelling, because what happens when something's irritated, our body swells, right? Well, that's how we get granulomas. That's how we get blisters when we wear those killer high heels on date night, right? So the tooth breaks through, the gum swells back over that sucker, and then it breaks through again. With gingival hyperplasia, it keeps swelling. And then the well-meaning therapist is like, oh, here's a pacifier if it's like working on non-nutritive sucks or nutritive suck, or here's the bottle, or all right. Now my other thought is, and I didn't ask you about this one, but Sabril. Sabril is a really nasty seizure medication that I've seen for my kiddos that have infantile spasm disorder, also known as the catastrophic seizure disorder, or known as West syndrome. And folks, please go check out the Epilepsy Foundation page. The Epilepsy Foundation page has so much information on these medications that Lisa has educated us about, and they have cutting edge technology and resources. But Sabril, y'all, you get 2 weeks on this drug, and then they take you off if they don't see a change in your seizure management, because what happens is that it causes cortical vision impairments because it eats away at the optic nerve and the occipital lobe. And I don't remember what part of the occipital lobe, but I just know like it deteriorates it. So what happens is that they lose their, they get tunnel vision until they get no vision. And I've had kids that Sabril was the drug that worked to stop the spasms. And it's not like we're saying like, I mean, you can't do these drugs. These kids need these medications to stop the seizures or the spasms, because big picture, those will cause more neurologic damage than the side effects of these drugs have on their PO intake. So, I mean, you're damned if you do, you're damned if you don't, but it's which devil do you dance with, you know? But it does behoove us to understand how this impacts their planning and the overall PO intake, because we need to be able to relay that and communicate that with, especially when the mama has the breakdown, because y'all, the mom's going to have the breakdown. She will sit with you, or you will sit with her in her living room, and she will cry, why will they just not eat anymore? And you got to be able to understand the, how do you say this? The pharmacological reason? Is that the
Right.
correct terminology?
That's correct.
The pharmacological reason why. So pull out the tissue, let the Irish leak, but then give them the science as to why. And that also gives hope, because some of these kids don't have to be on these medications forever. It's just get them through the hump. You know what I mean?
Mm-hmm.
Yes. Okay. Squirrel number 2. Okay.
Very important.
Oh my gosh. I love you. This is Lisa. You're like so delightfully nerdy. It's just wonderful for my soul. Thank you. Okay. All right. So I have to move us on because we have like 10 minutes and I have at least 2 more questions.
I know.
Okay. So I've treated several patients that have cardiopulmonary stuff. And I've wondered if any of these classifications of medicines, such as those treating like congenital heart defects, congestive heart failures, PDAs, persistent ductus arteriosus, layman's terms, the hole in the heart,
Mm-hmm.
or cystic fibrosis, or just asthma. Can those meds, and I'm sure that they do, how does it impact their swallowing and motility?
Well, this again is I taught one 8-hour course just on cardiopulmonary.
Oh
So,
my God, where did you
I'm going
teach
to kind
that?
of
I want to
hit the
see that.
highlights. Some is for my own company, or the company I work for called Select Rehab, and for nursing home people. But I also teach quite a bit for home CEU, or
Okay.
it's also called 360 CEU or whatever. And I'm working on like a 3-hour course, 2 or 3 hours, just on some of this pediatric med stuff as well. But anyway,
Okay, well, I want to recruit you to ours. Come do it for speech therapy PD, because my goodness, woman, we need this there.
okay. So there's about 10 different significant drug classes and lots of meds within those drug classes, whether it's the ACE inhibitors or the beta blockers or whatever. There's a lot of those that could be prescribed to a child with cardiac disease. So let's just look at a few of them in our last few minutes. That's ones that's more common and that we have to be really careful to monitor. The first is digoxin. So when I did some research with a cardiac nurse, I worked with a critical cardiac care guy, and he said they all call it dig. So I said, okay, I'll call it dig too. But digoxin, that just basically helps the heart to beat stronger and slower. So it allows the heart to pump more blood and oxygen to the body that we need that to happen. It could be used to treat fast irregular heartbeats like atrial flutter or supraventricular tachycardia, the fast heartbeat, or to treat
I was
heart.
ready to say that's super fast,
I
right?
know. I know. So the side effects that we should be concerned about is if they're taking digoxin, which they may need for their heart to pump the blood to get it to the body, is nausea, diarrhea, drowsiness, and dizziness. And if an infant is taking digoxin, what we would see if there's too much of a level, because there's a fine line between having just enough and too much. So if they're getting a little too much, with an infant, they would have cardiac arrhythmias. If they're older, let's say, 1 or 2 or older, then they would have a slower heartbeat, dizziness, pale skin, extreme weakness, loss of appetite, vomiting, diarrhea, changes in vision, all of that. So those are things we need to look for with digoxin. And then just know that the levels should be carefully monitored by labs or physicians, nurses, etc. And then diuretics like Lasix, furosemide is commonly prescribed, helps to reduce the fluid overload in acute and chronic disease like heart failure, renal failure. Could also be used with pulmonary or kidney diseases. And if they stay within the recommended dose, not too high, again, it's very, very fine line. They usually are generally well tolerated, especially in older children, but high dose therapy could produce excessive diuresis, which could result in hypotension, so the blood pressure drops too low, dehydration. They could be at risk for vascular clot formation, and they have to be carefully monitored through labs as well, because they should be monitored for signs of basically electrolyte imbalances where there's sodium, calcium, magnesium, potassium. Many of those could go too low, or they could go into metabolic alkalosis where there's too much acid in the blood. So there's a lot of risk with diuretics. So they have to be monitored, and there could be a lot of secondary issues there. With a PDA, the patent ductus arteriosus, that's basically, like you were saying, they need surgical repair usually, but
Yep.
if they are infants, they're not ready for surgical repair yet. And so for infants, especially if they are preterm, they need NSAIDs. The NSAIDs block the hormone-like chemicals in the body that keep that duct open, but they will not close a duct or help to close it if the baby is full term or if they're young children. The most common side effects of NSAIDs on these kids are stomach aches, heartburn, and nausea. So we're going back to the GERD. It's yet
GERD.
another reason they'll
Yeah.
have the GERD. They may also, NSAIDs could also irritate the stomach lining, minimize gastrointestinal effects. And if they are getting NSAID, they have to be given with food. So if they have
Oh,
GERD and it's difficult to take food, then you're going to further irritate the lining of the stomach if you give the NSAID without food already in their stomach. So
okay.
that's
Hold that thought.
Mhm.
The baby, y'all, our babies that have Down syndrome, I always assume, because I mean, let's be honest, those of us that work in home health, we do not get access to the medical records until I am verbally told otherwise by a member of their medical team. I assume that that infant has a PDA because of the increasingly high prevalence of PDAs in our population that has
Oh,
Down
wow.
syndrome. So until you are taught otherwise, please assume, because you're going to need to closely monitor that. Yep. So sorry, because I mean, they're already at risk for GERD management issues, but I mean, yeah, just all right. Sorry. Squirrel number 3.
Okay, and then for cystic fibrosis, a couple of things on this because I know we're kind of running out of time.
Yes.
There's a lot of meds to treat the person with cystic fibrosis. Could include pancreatic enzyme supplements, multivitamins, particularly the ones that are fat soluble, mucolytics to drive the secretions, antibiotics, including the inhaled oral or parenteral, the bronchodilators, which I want to talk about, the anti-inflammatory agents, the CFTRs, which I'll talk about those a little bit as well. That's what we see. So with the bronchodilators, with these, again, that's your anticholinergic, that it opens up the airway, but we have those anticholinergic effects. We also see a rapid heartbeat, headache and dizziness, nausea, vomiting, diarrhea, anxiety. They could also even have a skin rash or hives. And we can see nervousness or a tremor, like when their little hands get shaky, because it kind of just makes them feel like they're hyper inside of their body because of these bronchodilators. Also, we should only, if the child is crying and you're trying to give them a bronchodilator inhaler, it will not get to the lungs effectively because they're crying, screaming out, and they're not
Shallow
taking that.
breathing.
Yes, they're not taking that
Yeah.
to breathe in. And so it's not going to be effective if you give a bronchodilator while they're crying.
I'm just imagining some mom somewhere trying to hog tie
Yeah.
her youngin' up.
You're
Like,
going to take this. Yeah, yeah, yeah. Okay, so then here's a really interesting point that, and I love to collaborate with my friends who are working with the preterm neonatal babies. I was talking to a friend the other day, and she was sharing that, and I've looked up the whole article and all the research on this note, but babies who are born preterm, let's say 34, 35 weeks, their brains are not developed, right? So their brainstem is not yet developed enough to send the signal to them to breathe, for their heart to work, and all those things that are supposed to happen involuntarily. The brainstem cannot send those signals yet. So what are they given in an IV to help stimulate that signal? Caffeine. They're given a little bit of caffeine in the IV. Now, what do you think that does to the lower esophageal sphincter? It relaxes it, it opens it, and it increases the amount of GERD. But again, as physicians, as healthcare workers, as all of our team members, we have to think, what do we do to keep the baby or the child alive? And then we'll deal with all the other effects, but we first have to do what we have to do, right? And so that lower esophageal sphincter opens or relaxes, and it increases the GERD that we're dealing with. And then the last couple of things is the ivacaftor. I don't even know how to say that. And the tezacaftor. These are two things that are used to treat the cystic fibrosis. So the ivacaftor is a CFTR. So it's a conductance. No, it's a cystic fibrosis transmembrane conductance regulator, CFTR, that alters the activity. But the side effects of these are upper respiratory tract infections, headache, stomach pain, nausea, diarrhea, dizziness, joint or muscle pain, and cold symptoms where they're sneezing, stuffy nose, coughing, sore throat, all of that. And then, but it's helpful for age 6 and older. And then the tezacaftor, or the Symdeco, that is often used concurrently with the ivacaftor, the Calideco, is also 6 and older. And the side effects of this is headache, nausea, sinus congestion, dizziness. So those two are kind of working to amplify each other's negative effects. This one cannot be taken with most seizure meds. Many antibiotics are cannot be taken with it. They would have a drug-to-drug interaction, or St. John's wort. And so that kind of brings me to make sure that you're very aware of any mother who said, oh, it's just natural, I'm also giving them drops of this or drops of that, and because I heard it would help. So that's significant. They could have reactions.
I have so many parents that are like, oh yeah, we're just giving them a little CBD oil. And I'm like, wait, what? You can't just give a little CBD oil because, like, I mean, some of that stuff's not quite so purified as you think that it is. And we don't like our babies to be made high.
Yes, there can be drug-to-drug interaction. So if you must give them something that you bought somewhere, then we need to take them off of something else that could have a fatal drug-to-drug interaction if they're taking those two things. And
or natural oils.
Some regulated, right?
Yes. And some of the probiotics that people give now. So yes, all the, oh my gosh. Okay. You said one word that I needed help. It was something